So hi everyone, welcome to another day of the MCQs, and this week we are dealing with the abdomen MCQs, right? Abdomen and pelvis MCQs, and this is the second day. Let's start the first MCQ. The question goes like a 52-year-old man. See, age is also very important, like in history taking. Visits his physician because of a gnawing epigastric pain of 6-month duration that occurs at night or with hunger and is relieved by eating food. So it's probably a chronic pain, could be a gastritis by an ulcer, and is relieved by eating food. That probably tells us more in favor of a duodenal ulcer. A breath test performed in the office is positive for the presence of microorganisms that cleave urea. So urea breath test already done. Upper endoscopy is performed and confirms the diagnosis. If left untreated, this patient is at risk of catastrophic hemorrhage after erosion of which artery. Okay, so by the history, we know that we are dealing mainly with an ulcer that is related to the duodenal, so it is a duodenal ulcer. Okay, now they're saying that if this ulcer, because it's a long history, if there is a hemorrhage, right, if there is a perforation or a hemorrhage after this ulcer, then it could damage which artery, or anatomically which artery lies close to the duodenum. If you look at the relation of the duodenum that we have seen yesterday also, this is the anterior relation of the duodenum. This is the first part duodenum, that is second, this is third, that is fourth. You can see the main arteries are the superior mesenteric vessels lying in front of the third part, but mainly the ulcer are located over here, D1 part. Why? Because the gastric acid is coming over here only in the proximal part of the duodenum. So bleeding normally should occur, or the ulcer is normally in the first part duodenum. Now if you look at the posterior relations over here in the first part, we get to see some vessels. Now what are those vessels? The main vessel over here is this gastroduodenal artery, which is coming from the common hepatic artery, a branch from the celiac trunk. So it is this artery. If there is a posterior perforation of the DU or duodenal ulcer, it could damage this artery, leading to torrential hemorrhage. So remember, the answer over here would be our gastroduodenal artery, a branch of the hepatic artery, right? So second question, you are at a surgery and are about to mobilize the second portion of the duodenum and the head of pancreas. You note an artery and a vein passing anterior to the uncinate process of the pancreas and the third portion of duodenum. Which vessels are these? I hope this is by now clear. You've seen in a couple of questions, it is the superior mesenteric vessels which are lying in front, and these superior mesenteric vessels are the vessels, or the artery basically is a branch from the abdominal aorta. This supplies basically the midgut, and this artery over here basically goes into your mesentery of the small intestine, right? So it will enter into the mesentery, it will supply jejunum and ileum, and then it will give off obviously other branches like inferior pancreatic artery, ileocolic, right colic, middle colic, up till the proximal 2/3 of transverse colon, right? So remember that. Again, if you want to see, here is the superior mesenteric artery that we already have seen a couple of times. Let's see the question over here. Okay, a previously healthy 47-year-old lady comes to the emergency because of 2-week history of fatigue, abdominal distension and vomiting. 2-week history of distension, vomiting and fatigue. She drinks 6 beers daily. Physical examination shows pallor and scleral icterus going towards the liver side. A fluid wave and shifting dullness are present on abdominal examination going towards the situs side. The intravascular pressure in which of the following vessels is most likely to be increased? Basically, everything is related to the alcoholic liver disease, liver damage. It might compress the portal vein, leading to portal hypertension. So now they're asking you which vessel will have an increased pressure. So it is the portal vein which is having increased pressure. So all the vessels, all the veins which are opening into the portal vein, they all will have increased pressure. So if we out of these 4 or 5 options, if we can see any particular vessel that is a tributary of the portal vein, will have increased pressure undoubtedly. First option is short gastric vein. See, short gastric vein, it drains into splenic vein which forms the portal vein. So it will obviously have increased pressure, short gastric vein for sure. Right, splenic arteries. So arteries are separate. Arteries are coming from aorta. Inferior epigastric vein, again it's a systemic vein. Right, inferior epigastric vein. Remember, it lies on the medial aspect of the deep inguinal ring. Right, a systemic vein enters into IVC, not portal vein. Azygous vein actually is connecting. It is also systemic vein. It connects SVC to IVC, and the artery can't be. The answer is short gastric vein. If you look at an image over here, This image, what we are able to see is, you can see this whole portal vein being shown over here. This is the whole portal vein, right? And if you look at the vessels which are forming the portal vein, the two main vessels are the splenic vein over here, and you have the superior mesenteric vein over here. And the splenic vein, you can see the short gastric vein, the left gastroepiploic vein, the pancreatic veins, all these are draining into splenic vein, or they are forming the splenic vein along with the vein from the spleen itself. Right, and then you have the inferior mesenteric vein also, and then you have the superior mesenteric vein, and all that, they all form the portal vein. So if there is a cirrhosis here, if there is a pathology is over here, if the pathology is in the liver, it would compress the portal vein, leading to increased pressure, and that backflow pressure will be into all these veins. Simple as that. Okay, fair enough. Next one, a 43-year-old man is brought to the emergency 30 minutes after falling from a roof of a construction site. He reports abdominal and right-sided flank pain. Okay, so 43-year-old came after half an hour of a construction site. He reports abdominal and right-sided flank pain. Temperature is fine, pulse is 114, slightly on higher side, BP is low normal, 100/70. Physical examination shows numerous ecchymosis over the trunk and flanks and a tender right abdomen without a palpable mass. Very important finding of examination. There is ecchymosis over the trunk and flanks and the tender right abdomen with a palpable mass. Focused assessment with sonography, for that is a FAST, shows no intraperitoneal fluid collection. There is a ecchymosis, but the FAST is negative. FAST, this test which you do in a casualty, is negative. His hemoglobin is going down 7.6 for a 43-year-old young man is not good. You can understand the bleeding is happening somewhere. So hemoglobin 7.6, the most likely cause of his presentation is injury to which organ? Now see, that's a very important question. So it's a trauma history, he fell somewhere. He is having abdominal pain and abdominal and flank pain. Then ecchymosis is there, but FAST is negative. So there is some bleeding, but on the posterior aspect, by which the ultrasound is not able to picture out clearly. There is also flank pain. So probably it is not an intraperitoneal bleed, it could be a retroperitoneal bleed. Understand that. It could be a retroperitoneal bleed. We need to either open up the patient, that is doing exploratory laparoscopy or simple laparotomy, or you need to, if you can buy time, though I don't think because there is this ongoing bleeding, then you can go for CT and all. So it is probably retroperitoneal bleed, or could be a pelvic bleed, but basically it's around the abdomen only. If you look at the options, liver, spleen can be seen by FAST. Kidney is a retroperitoneal organ and also lies on the flank. Could be the bleeding, the source of bleeding could be from the kidney. Stomach and small bowel again are intraperitoneal. Answer over here would be the kidney. It would be a kidney bleed. Understand this, right? Fair enough. Next one, a long question. Let's see. A 54-year-old lady comes to the emergency because of recurrent episodes of fatigue, nausea, palpitations, and diaphoresis for the past 2 months. So past 2 months, this lady is having fatigue, nausea, palpitations, and diaphoresis. Symptoms usually improve after drinking juice, but during the past week, she has also been having symptoms approximately 2 hours after meals. So this generalized sort of presentation, past 2 months, improvement on drinking juice, having high amount of this sugar content, glucose and fructose. But from the past week, she again starts having those symptoms 2 hours after meals. She has no history of serious illness and takes no medication. Abdominal examination shows no abnormalities. Her fasting serum glucose is 46 mg per deciliter. Fasting is very, very less. Both serum insulin concentration and serum C-peptide are increased. It's a case of increased level of insulin causing hypoglycemia. So hypoglycemia, an improvement by having the meals, right, and increased C-peptide levels. Point out so was insulinoma, if you remember the medicine. A contrast CT of the abdomen shows 2 cm well-demarcated lesion in the pancreatic tail. So most of the islet of Langerhans histology we read are around the tail only, where you have the insulin. The patient is scheduled to undergo laparoscopic tumor resection. Which tumor? It's insulinoma, pancreatic tail tumor. Which of the following arteries is at greater risk for injury during the procedure? Now see, very beautiful question. Now the location identified is pancreatic tail and you need to remove it surgically. Which artery is at risk while removing it? So anatomically we should know what we are dealing with, understand this. So see, imagine this is the pancreas over here, just imagine. This area is the tail of pancreas where we have that insulinoma tumor, remember that. Now also do remember that here you have the duodenum, these are the four parts of duodenum going like this, okay. The tail of pancreas goes into an organ. Can you name this organ? Can you identify this organ? This organ is a spleen, right? The tail of pancreas enters into spleen, and if I ask you, this area is where the tail of pancreas entering into the spleen is bounded by ligament. Which ligament is that? As the pancreas is a retroperitoneal, it enters into spleen from behind. From where? From behind. This ligament is known as splenorenal ligament. That is, it is connecting spleen to which kidney? To the LK, left kidney, remember it. And this splenorenal ligament, if you remember, apart from having, if I am talking of content over here, apart from having one content is tail of pancreas, what else will it have? It will have the vessel going into the spleen. Why so? Because that vessel, splenic artery, is a branch of celiac trunk. Celiac trunk itself coming from aorta. Aorta is retroperitoneal. So therefore, the second major content will be the splenic artery and vein, or we can say splenic vessels. So which artery is at risk while dealing with this? Obviously, it is going to be splenic vessels. Let us see if you have this as the option. Here we have it. Splenic vessels will be at risk. Will be at risk. Let us see over here. This is where you have the splenic artery going behind the stomach and entering, and this is the content of splenorenal ligament, remember, or lienorenal ligament. A beautiful question. Let us rule out other options also. Let us do complete. So common hepatic artery will be more on the right side. It has nothing to deal with anatomically. It is not related to the tail of pancreas. Left gastric again coming directly from the celiac trunk, no relation to tail of pancreas, remember. Inferior pancreatic duodenum is coming from superior mesenteric artery, will again no relation to the tail, but it has relation to the head of pancreas. Inferior mesenteric again, it is going to supply the hind gut, no direct relation to the. So answer over here is the splenic artery. Anatomically very important, right? So that's all guys. I hope you guys are enjoying. So if you are liking, then press the like button, do share, and any comments to let us know. Thank you.